Hello, I'm Blake Hawley, a P4 at the Texas Tech University Health Sciences Center in Abilene. Today I will be discussing the kids list. Alright, so the main points I hope to cover in today's topics are to describe the history and development of the kids list, to discuss the kids list relevance in medical practice, and finally demonstrate the use of the kids list through a select few examples. So firstly, what is the kids list? Well, the kids list comes from an article called Key Potentially Inappropriate Drugs in Pediatrics. It was recently published by JPPT, or the Journal of Pediatric Pharmacotherapy and Therapeutics. This list presents a consolidated list of medications associated with the high risk of adverse drug reactions, or ADRs, in the peds population. And remember, ADRs are unintended responses to medications at therapeutic doses. Many ADRs are not harmful, but some can cause significant morbidity and mortality. Therefore, in essence, the list acts as a reference tool to improve medication safety with our kids. So the idea for the kids list spurred from the Beers criteria. The Beers criteria started by Mark H. Beers in 1991 with the intention to identify medications with increased risks, or ADRs, in those 65 years or over. It was originally based on expert opinion, but has been expanded by the American Geriatric Society with more evidence-based recommendations. It is usually updated periodically, with the last time being in 2019. It's used by a variety of institutions, including Texas Tech. It is a very popular place to start with medication reconciliation and to check therapy recommendations in this really vulnerable population. But hey, geriatrics isn't the only at-risk population, and pediatric practitioners wanted a list too. So it's no surprise ADRs occur in higher rates in pediatrics, especially neonates. This is partly due to limited amounts of testing in the pediatric population for drug approval. Pediatric consent is more complicated, and their pharmacokinetics is often different than adults. New incentives like the Best Pharmaceuticals for Children Act and Pediatric Research Equity Act has increased the incentive in pediatric research and drug approval. However, roughly 50% of medications remain off-label for children, exhibiting questionable dosing strategies. As I briefly mentioned, the body's physiology and pharmacokinetics vary as you go from neonate to infant to child to adolescent. These variations in the pediatric population leave room for more potential ADRs. Overall, many of these ADRs are avoidable with proper learning and the right resources. So first, let's look at the methods of how the kids list came to be. The team for constructing the kids list was selected by the PPA Board of Directors. 7 different pediatric pharmacists were selected with careers in a range of areas such as critical care, hematology, oncology, and general pediatric practice. Everyone on the panel completed a conflict of interest disclosure form at the beginning of each meeting. So in order for a drug to be on the list, it had to meet specific inclusion and exclusion criteria. To be included, the ADR had to be from the pediatric population, it had to be commercially available, its reaction had to be clearly from the medication itself, there must be a safer alternative to treatment, and the incidence, frequency, and severity had to be greater in peds than adults. A variety of substances were excluded due to their required need, lack of evidence, or legality. These included vaccines, herbal products, drug devices, PN components, contrast agents, and illicit drugs. Also teratogenicity and breastfeeding, because this is not a list for pregnancy or lactation. Overdose was not included because many medications are toxic if you take too much of them. And of course, allergic reactions were also excluded because many allergies are very specific to the individual. So regarding the developmental process, the panel began with literature search for drugs or excipients. Articles and sources were accessed for eligibility via the PRISMA strategy. Electronic databases like PubMed were scanned using mesh terms. Lexicomp and Pediatric Neonatal Lexicomp were searched by Lexicomp staff and then narrowed by the panel. One panel member searched through FDA Sage Communications for a month. Expert opinions were taken into account, but were researched and reviewed by the rest of the panel. Regarding review and panel discussion, the panel held weekly or monthly meetings for over a year. Panel members followed up with PubMed research between meetings to return with recommendations and deliberate on the overall quality of evidence for inclusion or exclusion from the list. Regarding internal or external review, so once the manuscript was achieved, the list underwent review by an interprofessional group of pharmacists, nurse practitioners, pediatricians, and other pediatric medicine experts. Their comments were used in revisions, and then the manuscript was then electronically submitted for review to 1,500 PPA members. Anyone could submit comments for up to 30 days. The end product was 67 drugs and 10 excipients. So here's a portion of the list. If we break this down, there's the drug or the excipient and the risk or rationale, which are pretty self-explanatory. There's also the type of recommendation, the strength of the recommendation, and the quality of evidence. I'm going to go ahead and define these three even further. So the quality of evidence represents the aggregated amount of published information collected. They modeled this parameter after the grade recommendations used in the Beers criteria. This ranges from very low to high, so like a high quality means further data is unlikely to change the recommendation. Moderate suggests more research may impact the confidence. Low means more information is likely to affect the confidence in the recommendation. And very low means, well, they're fairly uncertain because there is scarce amounts of data. Moving on to the strength of the recommendation. A strong recommendation means most clinicians would agree, while weak recommendations indicate more variation among clinical decision making. With weak recommendations, clinicians should look at the patient and situation and combine this with their values to make the best choice. Lastly, the types of recommendations themselves. So avoid classifications mean most clinicians would agree to avoid due to the risk of adverse drug reaction. Meanwhile, use with caution means the recommendation may have weaker backing, or sometimes the need may outweigh the risk. I also thought it was worth mentioning that the panel uses a little bit different age classifications than what you might normally see. So your neonate is still your typical less than 1 month, infants is less than 24 months, and children is more broad. It really just means anyone less than 18 years old, so your adolescents actually fall within their children category. So overall, pretty self-explanatory, but worth defining. So breaking it down, most meds were prescription-based. The main categories were anti-infectives, antipsychotics, dopamine antagonists, and GI agents. Overall, 39 of the 67 drugs were strictly avoid, and 23 of the 67 were strictly used with caution. 5 drugs were a combination of avoid and use with caution, depending on the age range. Of the 10 excipients, 6 were avoid and 4 were used with caution. Overall, much fewer of these avoids were strong recommendations compared to, say, the Beers criteria. The Beers criteria is currently better established and contains more data behind its recommendations. With time, stronger recommendations will develop with the kids list. So now that everything has finally been defined, let's take some time to actually apply the list. So let's start by saying a first-time mother comes into the clinic with her 10-month-old infant. The child is teething and therefore very irritable and having trouble sleeping. The mother already consulted a friend, and the friend claims she used Orajel Instant Relief for teething pain a few years prior with her little one. The current mother claims she could not find a medicated infant formulation, and so she bought regular Orajel, but decided to consult you before using the medication. So where do you start? Well, you know the active ingredient in Orajel is benzocaine. You could look at pediatric or neonatal lexicomp and see benzocaine formulations are only recommended in those 2 years of age or older. You could keep scanning through lexicomp, or you could go to kids list. So what does the kids list say? Well, it says benzocaine can cause methylglobinemia. You know that this is when methyglobin is highly elevated and you're basically not getting enough oxygen. It can be life-threatening, so this is certainly an ADR most clinicians would want to avoid. This is a strong recommendation, meaning most clinicians would also agree with this recommendation. And there's also high quality or amount of published evidence. So the kids list references the studies they used to reach their conclusions. In this case, I reference multiple cases and reviews, along with a couple FDA communication releases. So Orajel actually discontinued their medicated forms of their benzocaine teething products after the latest FDA release. Of course, in the end, you wouldn't recommend Orajel for an infant, but probably more of non-pharmacological treatments such as a wet cloth. Alright, so moving on to another example. So say a father comes in with his 5-year-old for a yearly checkup. The father says the child does seem to sometimes develop a cough and congestion with seasonal changes and colds. He wonders if a children's Vicks Vapor Rub is a good bedtime option during these times to help with the cough. So in children's Vicks Vapor Rub, there is camphor, menthol, and eucalyptus oil. A quick look at Lexicomp says menthol and camphor products shouldn't be used for those under the age of 2. Overall, it looks relatively safe, but you decide to take a look at the kids list. Well, camphor is on there with a use with caution recommendation. However, the strength of the recommendation is weak, so there is some discrepancy between clinicians about the ADR risks, and the quality of evidence is low, so there doesn't seem to be a large amount of evidence out and about. If we look at the studies the list references, we can see camphor does pose risk for toxicity. If a child ingests a mouthful or if you put copious amounts around the nose, it is rapidly absorbed into the GI tract and can lead to central nervous system effects, like seizures. Smaller amounts are more toxic with infants, thus it can be used only in those greater than 2. Most of the data is based around case reports, so exact toxicities kind of vary. Therefore, in the end, you can use your clinical judgment to advise the father. The children's formulation of Vicks may be fine. However, better alternatives to treating the child's symptoms do exist. You may want to discuss potential allergies and antihistamines, or even see whether the child may have asthma, so more questioning is warranted. So I hope going through some examples shows how you can utilize the list. However, as you look through the medications, there may be some drugs not there you would have expected. Over-the-counter pediatric cough and cold medications are not. A lot of these preparations may contain diphenhydramine, ibuprofen, or acetaminophen, but their ADRs are often linked to overdoses, which was an exclusion for the criteria. If used properly, these OTC medications are actually quite safe. Fluoroquinolones were thought to be beneficial in certain subsets of situations such as cystic fibrosis, UTIs, or community-acquired pneumonia. They didn't want to discourage clinicians from using these medications when use was warranted. SSRIs is another class you might expect to see due to their black box warning of increased suicide risk in children. But once again, the panel thought that the benefit outweighed the risk, and there wasn't any particular SSRI to single out at this time. So in conclusion, this list can only be applied in the United States because it can only involve drugs approved by the Food and Drug Administration. Remember, this list helps improve safety, education, and quality control. However, it's also important to emphasize this list is just supplemental or a place to start. Our clinical judgment is the end-all, be-all. The kids list mainly acts as a guide. Lastly, we have to remember the kids list is only the beginning. The panel plans to expand and update the list periodically, just like the Beers criteria. Their goal is at least every 5 years, so we can expect this list to grow and be more defined with time. So you can find the kids list through the Journal of Pediatric Pharmacology and Therapeutics on PubMed or the JPPT website. It's not on Lexicomp yet, but I'm sure it will be with time, just like the Beers criteria. Of course, that next source is the updated Beers criteria. These are the references referenced in my first example. And these are the references from my second example. Anyway, thank you so much for your attention. Hopefully you have a better understanding of the kids list. Over time, I'm sure this list will expand and be utilized in pharmacy and other branches of healthcare. If you have any questions, always feel free to send them our way at TTU HSC SOP. Have a great day, y'all.